evening. Welcome to another episode of a month-long e-conclave on breast cancer, brought to you by the IHW Council in Novartis, India. Today on our show, we will discuss the way to affordable and accessible breast cancer care. But before we start the discussion and welcome our esteemed panelists, here's a snapshot of the ground that we've covered in the Breast Cancer Action Month, addressing India's breast cancer epidemic, moving from awareness to action. We kickstarted our month-long campaign on 1st of October, and this is what has transpired in all the shows that we have so far.
Breast cancer is the #1 type of cancer in women today. To exhort and encourage all of us to move from awareness to action, IHW Council, in partnership with Novartis India, embark on month-long mega virtual conclave, Breast Cancer Action Month.
Women empowerment के प्रतीक हैं मैडम आनंदीबेन पटेल और नजमा हफ्तुल्ला जी। मैं आग्रह करूंगी कि उनका ये जो भाषण होगा, जो उद्बोधन होगा, वो देश के कोने कोने तक जाएगा।
मुझे आज ब्रेस्ट कैंसर एक्शन डे से उम्मीद है कि जागरूकता और उपायों के बारे में लोगों को बताकर हम देश में ज्यादा लोगों के बीच कैंसर होने से रोक सकते हैं। इंटीग्रेटेड हेल्थ एंड वेलबीइंग काउंसिल और वुमेन हेल्थ वेलनेस फॉर वुमेन एम्पावरमेंट फाउंडेशन के सभी महानुभावों को एक बार फिर बधाई देती हूँ।
I'm confident that the contribution of the Integrated Health and Wellbeing Council will certainly help in checking and treating cancer in different parts of the country, for which they should continue their endeavor for fulfillment of what they have targeted.
Awareness around cancer, awareness around women health, awareness about around all the artificial things that we engage in, and vanity has its own impact on our health, and I think it's time to turn the tables on the other side.
The problem is really at two levels. One is, like I said, with the media centering a lot of communication around what is significant in that month. And the second is, as a society itself, we just don't want to mention the word breast.
Why do you think that people in US, they are diagnosed stage 0? 80% of the ladies, the disease is diagnosed in stage 0, 1 and 2, while in India it is 80% stage 3 and 4. Why? Only one reason, the awareness.
We have to create a complete ecosystem which can really help early detection, early treatment, and help patients live a longer and healthier life.
Every morning you get up, you brush your teeth. Similarly, once in a year, for example, it is your birthday, it is your wedding anniversary, or any specific day, you have to go and see a doctor whether there is a complaint or no complaint.
More and more ideas are emerging towards action, and I really appreciate that from awareness to action to make an impact is where we are moving.
And I think COVID has shown us that we can learn a lot, and we can learn it fast if we have to. And I think my call to action would be, let's take this learning and apply it to cancer and move fast with inclusiveness, move fast with inclusiveness of the stakeholders who are involved.
I think from the relatives' point of view, we need to just give time to the patient, listen to the patient, do not force your views.
It's very important for us not only to treat the disease, but to treat the patient as a whole. We need to treat the family. We need to treat society as a whole by creating awareness of the disease itself. So I think it's something that we, need to do it on a very holistic scale.
Last word would be, of course, cancer is a word, which scares all of us. But today, with the most, I think modern medicines and very good doctors and lovely treatments which are there in hand, definitely, I think we can beat it. That would be the thing. So let's just be positive and we can do it. That would be the word.
But I think there's a role also for not just for the companies, but for the healthcare system, so the government funding to really roll that out so that more and more patients can access that, whether you're rich or poor. Like I said, some of these interventions are not expensive, and it's all about we heard from everyone else about there are people out there that want to help, and all we have to do is connect people.
Our perception of what's happening with what we're going through really dictates how we work through the illnesses that we have, and how we connect not only our mental well-being but also our recovery to our thought process.
Thank you all for joining us today. To fight against breast cancer, we need awareness and action at all levels. And to make every woman and man become the ambassador of good breast health, we at the IHW Council have begun a mass movement of taking a pledge that each one of us will talk to at least 5 people about good breast health. The lawmakers, social leaders, influencers, and medical experts who are joining us to chart the way forward to prevent breast cancer in India have also shown their exceptional support to this campaign. We're also thankful to Novartis India for their support to this movement. We request all our panelists and all those who are watching the show today to please take this pledge by clicking on the comment box of this live post. You can also go to our website, www.ihwcouncil.org, and sign this pledge. Once you sign the pledge, you will receive a certificate with your name on it. Do share the same on your social media pages by tagging at least 5 people to take this pledge forward and to promote breast health amongst everybody in our country. Please strengthen this movement. So I request all of you today to please sign this pledge. Now, coming back to our topic of discussion today. Now, world over, cancer is amongst the most expensive diseases to treat. Now, the ICMR has estimated by the end of this year, there will be nearly 14 lakh cancer cases in our country. Treatment of breast cancer could vary between, say, a lakh to upwards of 20 lakhs, depending on the stage of the cancer, the type of the therapy, and whether it's treated in a public or a private hospital. Treating critical illnesses is known to be one of the major reasons to pull down some families into extreme poverty in a country like ours. Because of lack of awareness, many breast cancer patients present themselves in later stages, which are harder to treat and, of course, more expensive. Many of them drop out of the course of treatment because of the cost involved. And this also leads to higher mortality rate in India. In an underinsured country like ours, a staggering 90% of the cost of cancer treatment is paid out of pocket. How can we make breast cancer care affordable in India? Will increased health insurance be the way out? Will the government's Ayushman Bharat scheme help reduce the out-of-pocket cost of cancer treatment for those who are eligible for it, those whose income is not very high? To discuss this, we have a panel of experts joining us today. Please welcome Dr. Poonam Padal, Health Oncology Department, Manipal Hospital, Bengaluru. We have Dr. Vijay Anand Reddy, Director, Apollo Cancer Institute, Hyderabad. We also have with us Dr. Rajesh Bolam, Consultant Medical Oncologist and Hemato-Oncologist, Yashoda Hospital, Hyderabad. We have Dr. Sneha Bhuyar, Chairperson, Study on Female Breast Diseases Committee, FOXI 2019-2021, and President, ISOPARB, Vidarbha Chapter. We're also happy to have with us Dr. Sachin Bajaj. He is Founder Director of Ujala Cygnus Hospital and is expert of the Market Access Program, PMJAY. We have Thomas Lemaris, the Head Market Access and Alliance Management, Asia Pacific and South Africa for Oncology, Novartis Singapore. And we have Renu Sehgal. She's the President of Sahitya Charitable Welfare Society, Chandigarh, and she's a breast cancer survivor. A warm welcome to all of you for joining us in this show, and we're very happy to have all of you with us. So let me start with you, ma'am, Ms. Patil. Now, in our country, the out-of-pocket expenses for cancer treatment are fairly high. Now, it's nearly, unaffordable for a large population of our country. So, what is the way forward? In our country, we spend a very small percentage, just 2.5% of our GDP on healthcare. Maybe COVID is going to change that. But and so far, of all the investments made in healthcare, it's largely the private sector that has been doing the heavy lifting. But the private, cancer care in private sector is fairly expensive. So going forward, who is going to be, catering to the large number of cases that are going to come up with limited means to pay?
So this is where, as you said, that awareness is very important. If the cancer was diagnosed in an early stage, naturally the cost of treatment would have come down. The cure rates would have gone up, relapses would have been less. So there is absolutely no undermining of the importance of awareness and reducing the risk factors and early detection of breast cancer. But having said that, despite all efforts from everyone, we do find patients coming at a little advanced stage, and we can't tell them that, so sorry, you were not able to detect it early and we can't put our hands up. So we have to treat them. And many of them are going to be cured, and many of them are going to be long-term survivors as long as they are not in metastatic disease. Even if they are in metastatic stage, that is stage 4, still many enjoy a good quality of life for quite a long time, depending on the type of breast cancer. So early stage is one class apart, and there the treatment is of a limited or a finite duration. And depending on the type of breast cancer, there we have hormone receptor positive breast cancer, hormone receptor negative breast cancer, HER2 positive breast cancer, and HER2 negative breast cancer. So depending on the receptors, the treatment is dictated. Now, amongst them, the most expensive would be where HER2 positive breast cancer, where anti-HER2 therapies are expensive. Then comes where the ER/PR is positive. In advanced disease, there is a class of drugs known as CDK4 inhibitors and CDK6 inhibitors, which has indeed made a change in the treatment of metastatic breast cancers. Now, this is most expensive part of the whole therapy. And I think giving all respect to the innovator brands, the way ahead is getting biosimilars. So
Okay,
when we have,
biosimilars at an affordable rate will perhaps take a few more years to come by, but let's hope we make progress towards that direction.
Yes.
Dr. Sneha Bhuyar, I wanted to come to you because perhaps you can give us some kind of perspective from the government's point of view. Now, you see a lot of women patients with a lot of women-related health issues. They don't want to be burdens on their family. But in a country where we do not even have defined regular screening to detect cancer, I mean, we don't have a system for early detection, and then we say you got to pay out of your pocket. Too bad it's late stage. I mean, it sounds so unfair, and life is unfair. But you don't want to be a burden on your family. So how do we go ahead? Do we just take insurance? We are underinsured in any case. Can the government step up to pay part of this treatment cost? How do we go ahead?
Yeah, actually, thank you so much for this question. In fact, I'm very happy to know about the government's initiative, the Ayushman Bharat, which was coined in 2017. This basically has two flagships: the Health and Wellness Centers and the National Health Protection Scheme. Now we talk about the Health and Wellness Centers. They're approximately 1.5 lakhs, and should the aim of having the services closer to people's houses. And we are so happy to know that they are catering the maternal health services, non-communicable maternal and child health services, the non-communicable diseases, and even the essential drugs and diagnostic services as well. I was surprised to know whether they are available for all the diagnostic and investigation procedures and all the treatment of the breast cancer as well. So second scheme was that National Health Protection Policy. Here also the government has given the covering the vulnerable, needy, poor families, approximately 5 lakhs per family per year. So that was for secondary and tertiary care hospitalization. So I think the government has done a good job. I'm very curious to know whether it is what is the status at present. But as Foxy, what we are doing, what our committee is doing, that I want to share with you, make awareness in the people. We are doing not only Foxy Press Committee, but the President Foxy, Dr. Alpesh Gandhi, all our committee chairpersons, we are taking initiative. We are realizing the doctors that breast, we have to take it, consider it as a gynec organ, and we are working at 3-tier level system. We are training the doctors, making awareness amongst the doctors, and giving them the realization, training the healthcare workers, and making awareness in the public sector. So this was the first training of trainers program we have organized at Manis in 2019, attended by approximately 400 doctors. This was with Brahma Kumaris. Then we have done many breast cancer awareness programs all across Maharashtra and other states of country as well. Here, all the obstetricians and gynecologists, they are personally training the health workers, and they are making awareness in the general public as far as the breastfeeding is concerned, because as you know, breastfeeding has definite protective role in breast cancer, and we are trying to conduct the cancer awareness programs across India. This was the conference also organized a focus conference at Pune in 2019. We had approximately 500 obstetricians and the BPNI people and lactation consultants and general public attended this conference. Last but not the least, I would just like to share this a month-long project which was organized at Yavatmal. 2019, we had organized this for the health workers with a dual purpose of screening the health workers, at the same time training them for self breast examination. So 2,500 health workers were screened and they were trained for examination and proper referral if at all they find some abnormalities. So I think these are the steps we can take for the public, that making lots and lots of awareness, training the health workers, training the paramedics and the obstetricians and gynecologists, diagnosing it at the earliest and making a very effective referral at the same time, making very effective diagnostic and management. I think funding is the major issue, but if you have these policies, definitely it should succeed.
All right. So the work, ma'am, done by you for awareness is amazing. And
I would just like to share here that the breastfeeding programs which we are doing there, they're attended by more than 15,000 common people. And the mega event which we recently organized had 60,000 viewers on all the medias. It was very well appreciated by Foxy. All the Foxy doctors were present. Thank you so much.
This is great. Awareness is, half the battle won. Dr. Reddy, if people come in early stage cancer, their treatment will be shorter and less expensive. But even across states, there is a difference in the cancer treatment cost, breast cancer treatment cost, and a great variance between the cost in a public hospital and a private hospital. So what can, the private hospitals do, the private healthcare system do to provide affordable and accessible breast cancer care to patients who come forward?
Hello, Anisha, can you hear me?
Yes. Is that
Hello?
Dr. Reddy?
Anisha, am I audible?
Right.
Yes, I can. Is that Dr. Reddy?
No, this is Dr. Reddy. Somebody else is speaking. I don't know who is that.
Dr. Reddy, I would request you to please go ahead and answer the question.
Right.
Please tell us what is the role of the private hospitals.
Am I audible?
Yes, sir. We can hear you.
Right.
Please go ahead.
In a public health hospitals, they know what they can offer, and they have limitations in explaining to the patient this is what we have, and so they have to be careful in counseling a patient. Whereas in a private sector, we are in a dilemma. Of course, we need to look at the socioeconomic status of the patient before we counsel them for the high-end treatments. But nevertheless, I think there is some kind of a bias if an individual is seeing a patient. So I personally feel that even in the corporate sector, if a team of doctors, a multi-specialty group of doctors would see a patient and counsel a patient, then the bias would come down, and then a proper treatment plan would come into enforce. Having said that, my previous speaker was talking about high-end treatments like anti-HER2 therapy and CDK4 inhibitors, but those are the options. But there are several other options which are reasonably cheaper and easier for the patients to take care. So, like anti-hormonal treatment, we all know anti-hormonal treatment is the best way to treat breast cancer patients, provided the tumor is
they have the
estrogen receptor
receptors.
positive.
Yes.
So in those kind of patients also, unfortunately, a lot of chemotherapy drugs have been enforced onto these patients. So that bias should go. That will happen only if it is a multi-specialty hospital and a multidisciplinary team sits.
But sorry to interrupt you, Dr. Reddy. Isn't it true that some patients are given chemotherapy because the government covers the cost, right? So they go to a public hospital. Another therapy may work better, but it's more expensive. So they go for the therapy.
There's something called choosing wisely. So it's a choosing wisely based on multiple factors and what is the benefit that the patient is going to get. So it's called cost versus benefit ratio. So you need to look at those before you advise any kind of treatment. Let me say, if you say that if you're giving a costly treatment of 1.5 lakhs, 2 lakhs per every 3 weeks, and end of the day, the patient is getting around 6 to 8 weeks extra life. So that is what we need to look at. So that 6 to 8 weeks life in a rich patient may be worth it. And that after putting it across to the patient's family, and they understand it's okay to get 6 to 8 weeks by spending another 8 lakhs of rupees, that is understandable. But for a middle class family or a lower middle class family, so with 6 to 8 weeks by spending 8 lakhs is not worth it. So you need to look at multiple factors before you advise, especially in a metastatic breast cancer. All these high-end drugs, in my opinion, should be carefully used. Now, when I say drugs, all these drugs also, I cannot understand and explain the cost of the production versus the cost which the patient is buying. So there's enormous difference. Let me give you an example of a drug which is actually costs around 800 rupees, is sold, the cost price on the vial is around 10 to 12,000 rupees. I think there the government can do some work. I believe in between there was a big difference happened, and they made a lot of changes in the costing of the drugs. Again, that eased out. So if that can be controlled, enormous stress on the patients would come down. These drugs, cancer drugs, should be made essential commodities, and the cost has to be controlled.
All right. So the cost of the drugs should be controlled is the suggestion that Dr. Reddy has. But let me come to you on that, Thomas, that, cancer drugs are expensive. They're expensive in India, they're expensive in America, they're expensive everywhere. And they're expensive because the innovator company works hard on research, spends years on that research, and spends a lot of money on that research too. So they expect that at least for a few years, they will get the innovator premium. Is this fair, given the load and the burden of cancer around the world? What can innovator companies have superior, fantastic drugs do to help out, those who may require it but can't afford it?
Yeah, I think there's many things that companies like Novartis can do. Not only Novartis, but I think also many other companies are doing that as well. And what we are doing is we have different price levels for different types of countries. So we have we look at what is the affordability like, is access like, are there government schemes that we can be part of, and I think that's something that is very important. That's something we are trying to work with the authorities in Indonesia and in Vietnam to get our drugs reimbursed at affordable prices for those systems. In India, it's now mainly out-of-pocket paying patients, sadly. It'd be better if there's more reimbursement for these type of therapies, but of course it has to come at a certain price that is affordable for more patients. And we do have very different prices in India versus what we have in other markets. So this is one of the solutions, but for me, the best solution is actual reimbursement. And this is also what we're aspiring to, for instance, for the reimbursement that PMJY wants to be. If that would be possible for our type of therapies to come on board in that kind of scheme, I think things are possible. But it requires a partnership from both sides to make that happen.
So, Thomas, who will bear the cost of the reimbursement? It's the government, right?
Sorry, please.
The reimbursement plan that you're talking of, the reimbursement plan, the cost is then borne by the government?
So that depends how such a reimbursement system is made up. So in Vietnam and in Indonesia, for instance, both have universal healthcare coverage, and they have subsidized system for the poor. So the poor don't pay any premiums, but the more affluent that also make use of the same system, they do pay a premium, and that makes it possible for the government to reimburse even innovative therapies. And again, at much different prices than you would pay in Europe and in other markets, or even some other Asian markets. But that is possible because there's a paying segment and there is a subsidized segment in those systems.
All right. So those who cannot or have difficulty in affordability will get it at a subsidized level, and those who can afford to pay will pay for a premium. And of course, these drugs in markets like India are priced differently from what they would be in markets like Europe and America.
Absolutely.
So, Dr. Sachin Bajaj, I want to come to you. Now, breast cancer is seen as an urban disease. Most companies provide annual health checkup for their employees. They also provide health insurance to their employees. Yet if you are, diagnosed with breast cancer, all these provisions don't help you. It could perhaps, the cost of the treatment becomes onerous even for city dwellers. So how can this current system be improved in your mind? The employer is giving you health insurance, perhaps it's not enough, and you get the screenings, the health checkup done as well. So why is it that in cities we see breast cancer going up?
Yeah, thank you, Nishabh. So I think as the Vietnam model teaches us, I think it's high time that we revamp each and everything about our healthcare systems. See, you can see the example of the pensions as well, right? Pensions run out so quickly nowadays because the life expectancy has risen up and the inflation index goes up every year. We plan for a pension of say 10 to 12 years, but the life expectancy is at least 20-25 years now post retirement. Same with health insurance. We take the minimum insurance available, 2 lakhs, 3 lakhs, but we forget that if we are diagnosed with a disease like cancer, even the initial 1 or 2 days may cost more than that, and the overall treatment for the next 6 months, a year may cost even more than 10 times that amount. So we need to be very, very clear on how much out of pocket expense we can afford for each and every illness. Ideally, of course, it should be completely zero, and I am all for abolishing completely the exchange of money at the point of care. I feel this fee for service model is completely erodes the trust between the patient and the doctor, because the incentives of the doctor and the patient are completely misaligned. So there's a lot of room for improvement. Unfortunately, in India, we're still thinking more on the insurance point of view, say Ayushman Bharat or whatever it is, still fee for service, still insurance based. But I would strongly suggest that if we can go for a outcome based healthcare system and completely capitation based, in which the doctors are paid on the outcomes and the health outcomes and the well-being of their patients, rather than the patients falling sick and then being paid for it, would be a paradigm shifter completely in the field of healthcare.
But Dr. Bajaj, how would that work? How does this outcome model work?
So we've seen it work in a lot of Western European countries. UK has implemented it very well. I think the outcome-based model, and we have been experimenting with it in a couple of districts of ours as well. So I think we just need to see, every model will have its shortcomings, will have its pros and cons. Uh, but I feel strongly that the insurance model, in which the doctor is paid only when the patient gets sick, and outcome based model when the doctor is paid if the patient is well all the time. I think these two are completely different systems. In the second model, the incentives of the doctor and the patient are completely aligned, that the patient
Aligned.
also wants to remain well, and the doctor is also paid when the patient remains well, right? In the first model, insurance model, the patient wants to stay well, but the doctor is paid only if he falls sick and comes to the doctor, right? So there is a big gap there. I feel the second model deserves a lot of consideration, and we must work hard on it.
Right. That is something definitely policymakers in our country should also dwell upon in figure out if such a model can work successfully in our country at whatever level it can. I want to come to Renu ma'am. Renu ma'am is a blood cancer survivor. Ma'am, I want to understand from you how the entire diagnosis versus the treatment, how long was the duration, and did the cost of treatment ever prove to be stressful for you?
I got blood cancer in 96. At that time, the awareness was very little. Even speaking the word cancer was very difficult for a person. I have cancer. And in the diagnose, I had slow fever and initially, and luckily it was diagnosed at early stage. And the treatment, there were many treatment options. And though we are coming from a upper middle class family, the treatment was very stressful. Those days, I was given interferon. It had to come from abroad at that time, and we took government help, and then we fought the case that cancer is a reimbursable in outpatient also. So all the cost was reimbursed, and that way I have been lucky.
And reimbursed by the insurance company? Reimbursed by who?
No, by the government. I am a government servant. I was a government servant. So all the, otherwise they won't give for out OPD. OPD patient, they won't reimburse more than 6,000, 500 or 6,000 a month. Get reimbursement, which I didn't want to do because my work would suffer. I am an architect. So my doctor also advised against it. So then I fought in the court with the Haryana government. And after that, the policy was changed, and cancer, this was OPD reimbursement was also allowed for some diseases.
Okay. OPD reimbursement for some diseases for government employees, right?
Yes.
So that again is a positive, but for a small subset. Why did you feel that the treatment was stressful?
Because it was very expensive, and I didn't know what to expect about the side effects. I didn't know. Didn't have any person to talk to. Then we telephoned Vandana Gupta in Bombay. She was running an NGO. She found 2-3 patients. I suffered from hairy cell leukemia. So hairy cell leukemia was a rare disease in those days. So Vandana Gupta found 2-3 patients, and they said they're doing well. And the stress was half at that time. And at that time, we thought of making an NGO so that others also can benefit from our experience. And we started Sahayata in 97. And we give financial help, awareness, education, holistic help to patients. And I would say awareness is very important, and early detection is key to affordable treatment.
All right. Early detection, of course, everybody is underscoring this, how it impacts the cost of treatment as
When
well.
we started, we were even, scared to take name breast cancer in front of colleagues. But now everybody is talking about it. And
yes, so that is the point, ma'am. We want to take the taboo away, and we want to increase awareness so that the burden of cancer care in our country reduces. Dr. Anand, I want to come to you. Renu ma'am was very fortunate that she found support groups. She was able to manage with her stress as well. The cost of care is an important factor in the total stress that a cancer patient has to undergo. Now, health insurance, is making treatment affordable for the salaried class, especially once they get admitted. And now we have new insurance plans, the cancer care covers, etc. So, do you think health insurance motivates people to take seemingly expensive health services like that for breast cancer?
Yeah, so that's a very, very important and pertinent question. See, earlier, if you look at a decade or 2 decades back, none of the insurance companies have covered cancer care as part of the insurance. And it's so fortunate now they realize that it's important, and most of the insurance companies are covering the cancer. So it is very, very important. Awareness, apart from the awareness of the diseases, detecting early, awareness about getting insurance is very, very important. See, when a patient comes to us in the clinic, once we know that the patient is insured, then without any bias, we think about what could be the best treatment option in this particular patient. Now, once the patient is compromised financially, then automatically our thought process changes. So that makes a huge difference in the patient care. So insurance should be promoted on par with the awareness about cancer. Insurance awareness also has to be get into the society.
Right. Dr. Rajesh Bonum, I want to come to you. Now, during our discussions over the month, we have seen that some states have very good care for cancer patients. Southern states like Tamil Nadu and Kerala are giving very affordable breast cancer care. Can this Can you tell us if you know anything about what it's like? Because there are some pilot studies being done in Telangana and some of the other areas also, so that mammograms are cheaper, screening happens more regularly, and chemotherapy in some government hospitals is free. So, what is it that you have experienced? And is this the way for reducing the burden of cancer in our country? More people going to public hospitals? How can the private hospitals also chip in?
Yeah, it's a good question. Me being working in all three sectors, government sector, or in a tertiary center where we do get more funding like Tata Memorial, and in the corporate sector like Yashoda, me into all the three sectors. Coming to the questions of question proper, that is being like state government schemes. Being before division, we both Telangana and Andhra were into the same, when it was the same state. We do have a scheme called as Arogyasri, wherein which cancer care was free because up to certain limit. Coming back to the specific breast cancer as such, now after being divided into two states, we have got separate Arogyasri for Telangana and separate Arogyasri for Andhra. So if you speak about treatment proper in the breast cancer, as the previous speaker said, the main costly therapy in a conventional breast cancer treatment would be HER2 targeted therapy, especially a drug called as trastuzumab, which is one of the landmark or a practice changing drug, which reduces the chance of disease coming back by around approximately 50% and increases the survival by around 30%. Such an important molecule, we don't have that covered in Telangana state as a part of Arogyasri. So, but it varies from state to state. The same drug has been covered in Andhra Arogyasri. And there are differences in between different states. For example, there's something called as Ayushman Bharat PMJY scheme that is applicable in few states, but which is not applicable in few. So I think the uniform health policies should be there, and the amount has to be based on the disease, not as per the drug per se, because the price which they give for the poorer patient depends on what regimen they use. For example, we use called some drugs called as taxanes. We use some drugs like docetaxel and cyclophosphamide. The cost given by the government scheme for a docetaxel plus uh, uh, doxorubicin is approximately around 3,000, whereas for taxanes it is 5,000. So with a limited amount of funds given to cancer care, it will be difficult for the healthcare providers to give the treatments.
All right. Just a suggestion to all our panelists here. We could, if we could refrain from naming drugs, we can talk about the class of drugs, but let's not take names because most people may not understand. And it'd be best if you just talk about the class of the drugs and not the names of the drugs.
If I can, Anisha, if I can add to what Dr. Rajesh Ballam has just mentioned. See,
Yes,
these
sir. Please go ahead.
below poverty line people would certainly come under this Aragyasri scheme, which is similar to Ayushman. So that is there in the state of Telangana, Andhra, Tamil Nadu, as well as in Kerala.
Yes.
But so these things, they have got a specific treatment, specific drugs which can be given in this under these schemes. So the higher-end drugs cannot be prescribed for these kind of patients. But most important part of the discussion, I feel, is a middle-class family or lower middle-class family. They are neither rich nor they can't be considered as a BPL or to go for these Aragyasri schemes. Those are the people who really get this financial toxicity. So those are the people that they cannot understand, they cannot compromise on the treatment, they cannot go to the public sector, government hospitals. They want to get treated in a corporate sector or a public sector, and they are the people who get stressed out on the finances. So that needs to be addressed.
Right, and
Can I share something?
Yes, ma'am, please go ahead.
Fully agree with Dr. Rajesh and Dr. Vijayanand. Just to add a bit, as Dr. Bolam has said, the whatever cover of breast cancer therapy is, it should not be for particular regime or particular modality of the treatment. It should be for all the types of cancer and all the diagnostic tests and all the modalities of treatment available. As we have already discussed about what prevention, I would like to add to it that when we are doing the awareness and screening, it should be available at a very high level of awareness through all the media, print as well as electronic media, and there should be high level of awareness and accessibility to the screening system and very effective referral system as well. At the same time, when we are doing such activities on a mass level, we have to make impression, or we have to make the people realize that it should be a holistic approach. All the physical, psychological, social, spiritual, intellectual, all the aspects should be given importance. Their diet, nutrition, their living style, all these things should also be realized that they should be taken care of. Thank you so much.
Yes, so this is also something, a holistic approach that we have discussed. Dr. Bajaj, we've had our speakers talk about the state level schemes in some of the southern states like Tamil Nadu, Andhra, Telangana, and Kerala. So these states have advanced health care covers, and some of them cover the expensive medicine, some don't. But how well do you think the Ayushman Bharat scheme covers breast cancer? And as much as I understand, it covers most cancers. So what is the major challenge in implementing of the scheme?
So yeah, as Dr. Rajesh also said previously, Anisha, I totally agree that the middle class really suffers from this. So one of our vendors recently, his wife was diagnosed with breast cancer, and he was a vendor in the hospital. And obviously, he did not have Ayushman cover because he was a middle class person, and he did not want to go to a government hospital to get treated, and he went to one of the best private hospitals. Unfortunately, his case was quite complicated, and there were metastases, and He underwent the wife. She underwent surgery as well, and then chemo, radio, everything. And he actually came to me saying that I've had to sell my house and I am short of money. So can you give me some advance payments on the material that I supplied to you, and I will keep supplying to you for the next 1 or 2 years. So this was something, he was completely in financial disarray.
Distress.
He had no money left, and I mean, this is very sad to see. He was a pretty much well-to-do guy earlier, but then he had to sell his car, his house, and he had to take advances from a lot of his customers, friends, family. And I don't know how long he will take to get back to the financial status he was in about 8 months ago. So this is something that's very distressing for all of us. It's very sad, it's heartbreaking, and that is why I say this kind of an insurance scheme. He had an insurance, a regular insurance of around say 2 lakh rupees or something, which ran out within a day or so. So this is very distressing. We've been champions of the Ayushman Bharat scheme for a long time, but as I said, Ayushman will cover your surgery costs, it does not obviously cover the higher end drugs like Dr. Rajesh was talking about. It does not obviously cover the higher end drugs like Dr. Rajesh was talking about. So her to everything, it does not cover all of that, right? So there is partial coverage, and I don't think it works very well for most of the patients.
Right. Thomas, any ideas that you have? You said you work for reimbursements where those who are not so well off would be subsidized and the government will reimburse, and the government or those who are the paying capacity will pay a higher premium. What about those
Yes.
people who are in the middle? In India, that's a very large set of people, the middle class, where they cannot go to a public hospital because the waiting there is so long that perhaps they'll be in a worse of the disease would progress, and the private hospital is so expensive that it's a huge strain. What can be done here? You have patient programs, but I guess they're very select. What would be the solution?
Yeah, I think that the solution is multi-pronged, because you can't. It's a combination of the supply of healthcare, because you said that the public hospitals are really overburdened with the amount of patients that they have, so they can't cater to the middle class, which is also very large in India. So in other markets, we see that there is that the public system is also contracting private institutions to deal with the overflow of patients. And of course, that's expensive, but they get very different rates from those private institutions that they would normally charge for their very affluent patients. So it's a social contract, you might say, between those private institutions and the government. The premium that I talked about in Indonesia and Vietnam, by the way, are not so high. So they are, let's say, $25 in Vietnam for the year for patients on average, and they get lower with the amount of people within the family that take such insurance from the government. In Indonesia, it's even lower. It's $1 to $2 a month. So it's pretty affordable for most. And then it also, of course, it's about us industry, not just the industry with innovative medicines, but also the generic companies that then have to fit their offering to the reimbursement system. So we need to have different sets of offerings for different types of hospitals, and tiering for the different levels of the socioeconomic class.
Right. Dr. Rajesh, what is then the solution for the middle class? Should we take, my employer gives me an insurance and it's not enough for my family. Should I then take it that I should take a higher cover, which covers critical illnesses, including cancer, and make that payment every year? Make it a cost of a healthy life, which is now longer. What is the way out? Dr. Bajaj wants an outcome-based healthcare system, and not an insurance-based one. But as a middle class, in our country, the healthcare system is the one which, so far, for the middle class, caters to those who are insured. Should I take that cost on a lifetime basis? Because I'm going to live longer and it's better to be prepared, having sunk that cost in? What should we do?
One thing is what I see is majority of the times when people do have also the corporate insurances, where do they work? Majority of the times the fund is limited. So apart from that, they should be having a private insurance which covers the critical illness. That is one of the important thing one should be looking for. And the other patients, when they do come to me, especially middle class, there are some third-party organizations. The previous institute where I worked was in Tata Memorials. Like there are many institutes like WeCare or Spandhana. There are few institutes wherein which there are third-party organizations, fundraising events. So that is where we get a few drugs. And the other thing is majority of the companies do have a schemes. Like for example, the treating doctor recommends there's something called as 1+. Like if you buy one drug, the other drug comes free. So you need to, like for example, individualize the patient's treatment. For example, if the treatment you feel is so essential, and the patient, by giving that treatment, the patient's expected life outcome is increased, then there are a few corporate companies as a part of CSR, like HDFC Bank. If you write to them that if the chance of survival is more than 50%, they are going to fund the entire treatment within the time of application. Within 7 days, they are going to transfer the fund to the treating doctor hospital. So we need to make use of pharma company by asking them for a scheme. Like there are few companies which give, like if you buy one drug, the other drug free. And there are a few third-party organizations with the help of the certificate from the doctor saying that this treatment is essential and it is going to improve the survival of the patient and the costly. And this is a genuine request. There are some third parties and there are fundraising events that can be done, and there are few corporates wherein which if the treating doctor says if the chance of survival is more than 50, especially when we were in Tata, we had tie up with few of the organizations like HDFC which do give complete funding, especially for the blood cancers.
That is definitely a positive note. But Dr. Reddy, for the middle class, how much can they bank on this? I do see fundraisers on Facebook for those seeking treatment. I know of an ex-colleague of mine in a previous organization that I worked with. Her daughter was diagnosed with a very rare cancer. She organized, the colleagues put together a fundraising plan. She was able to raise a large sum of money to take her daughter to New York for treatment. Research type, treatment that wasn't mainstream was given to her daughter with very positive outcomes. But these are one-off cases. For the general population, what is the way forward? To your mind, what is going to work best?
Honestly, barring the leukemias, which would cost not less than 10 to 20 lakh of rupees, which is going to be very expensive, most of the cancers, the majority of the treatment, the initial treatment, whenever you're diagnosed of cancer, would be less than 5 lakh of rupees. That's even in a private sector. So to get a 5 lakh of insurance for any general public, it's hardly 1,500 to 2,000 rupees. So the insurance premium compared to the Western world and the European world, in India, fortunately, it's very, very, very less.
I think you're talking for younger patients, Dr. Reddy. The premium for a 5 to 7 lakh cover is closer to 10,000 rupees for somebody who's 35, 40, and not to
so even if it is 5,000 to 10,000 rupees, it's not a major amount, and that covers all the diseases apart from the
from cancer, other than cancer.
You have a heart attack, you have a paralytic stroke, anything can be covered. So 5 to 10,000 rupees for a middle class man is nothing. He'll send his scooter or motorcycle for a servicing, we'll spend 5,000 rupees.
That's
so that need to be promoted on par with the awareness of cancer. It's very, very important that insurance plays a major role in covering middle segment class of people. So that will take care in majority of the patients. 5 lakh of rupees, we feel so reassured when a patient has got an insurance of 5 lakh of rupees.
Right, definitely. We should be proactive about awareness and securing ourselves. That is an important part of getting off the financial stress of the treatment of cancer. Renu ma'am,
we would normally call the financial toxicity, apart from the cancer treatment
Medicine toxicity,
financial
yes.
toxicity is enormous on these unfortunate patients.
Renu ma'am, you fought a big battle in the court so that, your employer did cover your cost. What has been your learning and experience? One, of course, is greater awareness that we want to take the taboo out. People talk about it and work towards it, are proactive about screenings, etc. Through the work that you've done over the years, when we talk of awareness with grassroots level people, you also talk about insurance or things like that.
I didn't get you. Excuse
My
me.
question is, ma'am, I believe that you have been doing work related to cancer support groups for the last few years. And, our entire initiative is to increase awareness. And
Yes.
you have been doing that. So when we talk about self-risk examinations, going for, clinical examination, should something be wrong, do we also talk about, for people or families to get insurance to see that their healthcare costs are covered?
Mostly, many patients are not even aware of what the government schemes are. They sell off their house or land, and then they come to know that the government help is available. So we act as a bridge between. We tell them that government help is available, and we fill forms for government help, and we tell them to get themselves insured while doing awareness.
All right. So, that's an important part of the puzzle.
I don't
Dr.
know
Sneha.
the implementation. There are so many schemes, but
Yeah, I know.
Implementation
It's a big maze. It's a big maze, no doubt about that. Dr. Sneha.
And then the getting a BPL card is so difficult for I think
the needy ones.
The needy ones.
Dr. Sneha, all states have their own health schemes. So there isn't a one size fits all, right? There are some states who are not even, who have not adopted Ayushman Bharat as well. So how do we, and then how do we get those people insured whose incomes are not secured, whose incomes are very low? What is the way forward for them? Screening, awareness, it's all important, but once you get something, even if it's early stage, you need treatment. For the treatment you need money. So how do you communicate with those people who have not heard of insurance and may even find a little bit of insurance premium to be fairly expensive?
About the insurance, I can just say that there is an insurance scheme by the government which covers the poor, needy and vulnerable family, but practically I'm not aware of it. What we have been doing, that's what I can share with you, that whenever we are making awareness and we are making the people undergo self-breast examination and clinical examination, we are guiding them for further investigations if needed, because we have at least 4 medical colleges around. And these are the medical colleges who cater their services totally free of cost. So they are available. They have all the departments necessary, including the surgery, radiotherapy, and chemotherapy, whatever, even the other modalities of management they require. So we see to it that they get help of these government institutions and they sort out their problems. About the insurance, actually, I'm not much aware about it.
Right. Dr. Bajaj, the government has come out with a new plan, and we heard about this during the Independence Day. It's already underway. I think this is the National Digital Health Mission. Do you think that the NDHM will make implementation of Ayushman Bharat smoother for a disease like breast cancer? Because, COVID has taught us that technology can help us overcome many things. Could this be the way forward for effective and accessible care?
Oh yes, absolutely. So I think we've been discussing about digital health for n number of years now without actually getting to do anything. And if COVID has done anything right, I think it is this, that it has led to the promotion of digital health a lot. We've been discussing about Project Step One, which you know about, I think, for a long time. So when we started Project Step One as a small WhatsApp group in March, actually telemedicine was illegal in India at that time. So we started out anyways thinking that, okay, we'll push the government, we'll do some advocacy because this is the only thing that will work, right? And very luckily, the government listened to all of us, and then the telemedicine rules were brought about, and the NDHM was launched and everything. So I think just in addition to the fact that it will make the claims process smoother, it will lead to a lot of generation of the high quality data. The most important factor is that we'll work a lot towards preventive medicine after that and personalized medicine. I think once we have all the records of all the people starting from their birth, we can pinpoint to a lot of factors looking back, seeing that, okay, these subset of people had this particular thing in their health records, and then they developed, this sort of cancer 20 years later. So Israel already does this very, very effectively. And I think we can jump onto that bandwagon and leapfrog a lot of other systems very quickly, because we'll have a huge amount of data to work with. Israel has a very tiny population, but still they are much ahead of us in primary and preventive healthcare and personalized healthcare. And if we have this humongous amount of data coming to us, we can pinpoint a lot of things on who needs to be taken care of, which factors we need to prevent, and which factors we need to work on to make sure that the outcomes are much better going ahead.
All right. So the digital health plan will be a step forward in the direction for preventing, and increasing awareness for prevention, screening, and well-being. That is something that can work since you'll have data to look upon. Thomas, in India, there are price caps on drugs as well. Now, for cancer, etc., those price caps may not be there. What's your view on them, on price caps? And in the government pharmacies, which is the the government pharmacies, they stock the generic drugs for all that treat all diseases, so that the cost for the patients is lower. Now, what is the way forward for generics when it comes to cancer treatment? I mean, will they? How readily are they available? How effective are they? Would you say something on that?
Yeah, so I think every healthcare system needs the innovative healthcare as well as the generics. So you need both. You need the innovative healthcare to be there for those cancers that really need the highest quality of the current care. And things that can be solved with generic medicine should be solved with generic medicine, because it's cost effective for that use. But it has to be of quality. So I think it's good to have generics in the system, and most Western systems have both as well. So they have a patent period wherein there is a certain there's protection of the patent, and then thereafter there is a mandated use of generics. So the generics come at a much lower price for the system, and so the system can use that money that they save on the generics and put it back into the innovation. And I think that's the way that it would work. But it does mean that we have to have high quality generics. And here, I think in some markets in Asia, there's still some work to do, because we can't always vouch for the quality of those generic medicines. There are very good quality generics in India, no doubt. But there might also be those of lesser quality, and I think that needs to be solved by the authorities as well. But next to the generics, there's always the need for innovative healthcare, and that has, of course, a higher price. But again, if we can work with reimbursement through states, through insurance companies, the large corporates, I think we will get there.
Right, definitely. If some of the insurers would also cover the cost of these drugs, it will definitely be a big help. But as much as I understand, most of the insurance cover the hospitalization and such charges. I'm not sure whether they cover the medicines of the cost of progressive drugs. Dr. Rajesh, insurance is one of the elements, right, for people to get good cancer care. What more can be done? You said that some states cover these medicines, some states don't. So as a patient, what should I do? Should I go to the other state and get my treatment done? Because there isn't just the cost of the treatment, there's cost of transport, there's a productivity cost, all those costs add up. How do we go ahead? Especially for middle class people, maybe, how do I manage?
The problem is, even if you go to the other state, it won't work. Saying that you doesn't belong to the state, the scheme works to the people residing in a particular state.
Okay,
so the chance of going into other state doesn't work. And one important thing I would like to tell is patients should be aware that there are many phase 4 clinical trials wherein which many of the costly drugs can be provided free of cost. Post-marketing drug surveillance, there are phase 4 studies wherein which majority of the drugs are provided free. For example, when it comes to immunotherapy or latest drug which costs around 4.5 lakhs, a drug called as pembrolizumab, there are some phase 4 studies which are the drug is given free of cost. So before you starting treatment onto the therapy, see in which way we can do the maximum benefit to the patient, whether he'll be eligible for any state scheme or whether he'll be eligible for compassionate drug access program. Because majority of the drugs are given free of cost based on the compassionate based program before they could be launched into the India, or there are sometimes schemes wherein which that can be provided in a subsidized way. So these are few of the ways, because majority of the times people don't mind going to different states if their drug is given free of cost. Recently we have got a melanoma patient wherein which we advised a drug called as pembrolizumab, which costs around approximately 4.5 lakhs. But patient didn't mind going to Delhi because the drug is free of cost there as a part of phase 4 trial. So one of the options a middle class person can be explored is the drug available free of cost as a part of phase 4 trial. Meaning we are not giving a trial on the patient, which is an approved drug, but as a part of phase 4, it can be given free of cost. Even that option can be explored.
Right. Thomas says Novartis do these patient support programs because the colleague I spoke of, her daughter was treated in such a phase 4 trial drug. Do most companies do this? How does it work? How does the patient come to know? Anything that you can add here?
Yeah, so we have different schemes, and I guess that's true for all, because the phase 4 trials are mandated by government in some cases. So there is a requirement of showing your safety and efficacy post approval for many drugs in India. We also have programs before approval. So in cases where the doctor feels that it is essential to have a certain drug that is still in the approval phase, patients can get these drugs for free before approval. That is case by case. And then, of course, we have the many access schemes post-approval for patients that are paying out of pocket. So there's all kinds of programs that try to lower the cost at the pharmacy level, but also over the whole treatment. So we try to cap treatment costs, for instance, for many breast cancer patients for drugs to a certain number of boxes, and beyond that number of boxes, it's for free lifetime. So those are different mechanisms through which we try to lower the burden for these patients. But if I may come back to the point that was made earlier about insurance, I think the insurance gets cheaper if more people do it.
Yes.
So it's if all the people in the middle class would see the benefit of such an insurance, there would be the possibility of lower premiums, or maybe not lower premiums, but better care that you could get reimbursed. For instance, outpatient care. But it can only be done if all of the population would enter, because then there is a pot of money to put into this care, and it will be sustainable. But it needs to be properly explained and educated to all these middle class, not patients, but people, before they get to be patients.
Right.
One quick comment can I make?
Very quickly, Dr. Rajesh.
Yeah. So for the middle class people who are not affordable, there's something called as third party organizations like Blue Tree, wherein which they provide the drug at no cost EMI. Even if the drug cost is around approximately 1.2 lakhs, they may not be affordable at a single point of time. But it is, if it is most essential, that the same drug can be given in a part of EMI basis. There are many third party organizations where they give no cost EMI. So even a few of my patients have utilize the service. Even that can be given an option, because they might be having money but they may not be able to pay at a single time. So this is one of the options we can give it to the patients.
Dr. Patil, in your experience, how can the cost of breast cancer treatment be managed for patients in the best possible manner?
Yeah, I think it has to be a shared responsibility. I cannot say that the government has to do everything for me. I must do something from my end as well. So even if I have an insurance which may be not of much amount, and I use it along with the government money and funds, even if I open a bank account, that bank account is linked to insurance, even if it may not be of a large amount, yet it helps the patients. I think the most important thing is a change in the attitude and mindset of people. People who have good insurance, sometimes they come with advanced disease and they say, now you give me the best treatment, I want to be cured, I have the money. They don't understand that money is not everything. It is the stage also of the disease that is decided. They feel that because they have money, they can demand a cure. Yeah, they demand a cure. So that is one mindset that needs to be changed. Second, as Dr. Rajesh Ballam said, a very, very valid point of clinical trials. The moment we use the word clinical trial, even if it is phase 4 trial, now phase 4 trial is of a drug which is approved for that indication. The minute we say clinical trial, 90% of the people tend to back out.
They feel the guinea pigs.
Yes, they feel that it's an experiment being done on them. They don't realize that the world has moved forward in the era of medicine because of clinical trials. And
so, ma'am, in your experience, have you managed to, get patients connected to these trials if they agreed? Were you able to get them connected with companies that may have a compassionate patient program?
Of course. For every patient, we attempt to do that. I have many clinical trials running. They are national trials, they are multinational trials, but it is extremely difficult to convince the patient, even if it is for an approved drug in a phase 4 setting. So I think the attitude, the mindset, everything needs to be changed, not just the awareness of the disease and not just the awareness of early detection. It's also these small things which ultimately make up the entire world of cancer treatment.
But do patients also despair and ask you tough questions like, if I spend the money, how much longer will I live? Will I live for sure? I mean, can you give them a guarantee like that?
No, we cannot give them a guarantee. But we do say that, see, the survival is linked to stage, and it is what it is. If you are stage 1, your chances of cure are much higher compared to somebody who's stage 3 or stage 4. And that is where, in India, it is awareness, and awareness. Even a simple thing which costs nothing, such as breast self-examination, which so many countries have said that, no, it's really not very effective. But I think that's the only thing that will work the best in India.
Yes, ma'am. But, that is step 1, right?
Yes.
I mean, if the studies don't show it works. So, I mean, after step 1, what is the way?
Women are diagnosed with mammogram even at an earlier stage. Now here we see a tumor which is coming off, say, 10 centimeters. We have seen 10 centimeters, the breast is oozing, bleeding, there's an ulcer. Yet they have hidden the fact from their family and they're sitting at home. So it is something
studies don't show that it helps, but in fact we would say these are the ones, the self-examination and clinical examination, early diagnosis, these are the ones who are saving the lives of the patients. I think furthermore multinational and multiple trials, largest trials or largest studies need to be done. That's what we feel, because this is our practical experience.
And what works in the US may not necessarily work in India. We have to work with our own conditions and find the best way forward.
So we should have multicentric larger trials.
Of course, that's on the doctors and the researchers to do. And we hope that we will get there. Dr. Patil, would insurance be a good way forward? Should people, we create awareness that, do a self-exam. Perhaps you should also create a awareness saying that, if you're going out for 2 expensive dinners, just forgo that and keep that money for insurance.
Sure.
Should that come along?
Yes.
Is insurance the way? Or is it going to be more of, the state playing a role in healthcare? Because in most countries, healthcare is something that the state insures for you. In our country, it's not.
Yeah, but then the population is also aware of the health and they go to the hospitals for regular checkup, compared to our country where people are very proud in saying that for last 25 years I have not been to a hospital. So I think that's a very unique situation that we have here. And it has to be a shared responsibility. I cannot put the responsibility of my health onto the state or to the center and say that government has to do everything for me. I should also say what I have done for the government to reduce their responsibility.
Dr. Reddy, we'll start taking some closing comments. Dr. Bajaj says that it should be an outcome-based model and not an insurance-based model. Dr. Patil says you can't leave everything on the government and say, you cover me, I may come as sick as I am, but you got to save me. What would you say in your closing comments is a good working model for us, where, breast cancer patients, deal with all other things, but perhaps not as much the financial toxicity, what you said, financial toxicity of the treatment? Dr. Reddy, can you hear me? Okay, I'll start taking closing comments from the other on the panel and return
before
to
that,
Dr.
I would
Reddy.
like to I would like to share something, because I think we are all talking about the awareness, screening and early diagnosis, and of course all the management and all the modalities of management. But I think we should think of something about prognostication as well. The test for prognosis, what has been talked of recently, we have to go ahead with certain tests for prognosis of the disease as well. Because whenever you have a postmenopausal woman with breast cancer who is in very early stage, maybe 1 or 2A, not of axillary lymph nodes smaller than 3, lesser than 3 rather, and their hormone receptor positive. So they are the one which are benefited by tamoxifen. So rather than just giving that tamoxifen for years together or not giving at all, we have to go for certain prognostic test which can definitely tell you that whether this patient needs the post-operative medication as well, and whether it's going to help the patient or no. So nowadays, I think they have come up with a study saying that giving tamoxifen for 10 years, it's going to help a lot for preventing recurrences in these patients. So previously we were giving for 5 years, I think. So that's the reason we should go ahead with the prognostic signature test for these patients as well. That's what my opinion is.
But Dr. Patil, what would you like to say in your closing comments? Dr. Sneha has mentioned prognostic testing. Imaging is also advanced a lot. All imaging may not be covered by insurance. So what could work best for
as
Mr.
Mr.
breast
Bajaj
cancer?
said, that we have to move from a sickness to wellness model. I think that is very important. And I look after myself. When I am in need of help, I take help from the state, or I take help from the center. And one more thing that I forgot to mention earlier, to add to Dr. Rajesh's comments, there is CM fund, PM fund for all patients who are not able to afford. We do get something from there. It may not be the whole cost of treatment, but every patient for whomever we have applied, we have got some amount. So I think that also helps to the patients to a large extent. That also should be made to realize all the patients should be told about these things if they are not able to afford. So,
all right. And the onus is on the doctors and the treating physicians to inform them about that. All right. Dr. Rajesh, what would you like to say? Our panelists have given us a lot of, different aspects. Dr. Sneha also spoke about prognostic testing. Can this be done on a wide scale basis? How effective it will be to manage the cost of treatment in later years and ensure there's no recurrence? What would you like to say in your closing comments?
I think we should concentrate more pre-disease evaluation. That is, we should more give awareness not only about the disease treatment, insurance, and manage. The thing which we have not spoken in the last 1 hour was healthy lifestyle and how do we prevent, how to reduce the risk of breast cancer.
We have said already.
Yeah, I think we're having a
we're
having a signal problem.
I think initially we have talked about this awareness, screening, and healthy lifestyle, the healthy diet and healthy lifestyle, the regular physical exercises and medication and all these things.
Dr. Rajesh is with us. Please go ahead, Dr. Rajesh. We lost your connection there.
Yeah, so I think we should concentrate more on reducing the risk factors and making the prevention. As we know, as the saying goes on, prevention is better than the cure. So one of the major reasons why we have seen increase in breast cancer incidence is more of urbanization. So obesity, cutting down the weight, healthy lifestyle, exercise, and these are the important things which should be told to majority of the women, so as to they reduce the risk of their breast cancer.
Right. But Dr. Rajesh, I mean, a healthy lifestyle could prevent many diseases, not just cancer. This is something which we want to, of course, everybody should be aware of. The one question was, do you think prognostic testing can also help in reducing the cost of treatments?
No, actually, this what you are talking about is the prognostic. These are not prognostic tests. Whether the person can have cancer, these are the tests for diagnosis. And what we are talking about, the test for prognostication. Diagnostic tests are to be done before confirmation.
No, I understand.
Yeah. And
I was asking Dr. Rajesh if he thinks that should also be a part of the plan for the treatment of breast cancer.
So we need to decide the treatment based on breast cancer. Like for example, there are few tests like ERPR, HER2, which what we call as conventional IHC. So based on that, this will help us to decide what therapy to give, because all patients might not require hormonal therapy. All patients might not require HER2 targeted therapy. So post-operative specimen, we do some tests like ERPR, HER2, and something called as in the nodal status, which help us to determine which patients require radiation, which patients benefit from hormone therapy, which patients benefit from HER2 targeted therapy. So these actually many of the clinicians know it, so I haven't discussed much on it, but we need to decide the treatment options based on the histopathological report. And coming back to the prognostic tests, the tests are very costly, and the clinical acumen majority of the times might help you in deciding whether this patient requires a chemotherapy or not. We can judge, because the majority of the prognostic tests are very costly, like mama print, oncotype DX. They are very costly. You can use a clinical judgment whether this patient requires a chemotherapy or not. Any tumor which is more than 2 centimeters nodes positive or HER2 positive, triple negative, this requires.
All right. Dr. Bajaj, what would you like to say in your concluding remarks on how to make breast cancer treatments affordable and accessible?
As I said, Anisha, before, and that India as a country does not have enough money to spend on sickness, right? The insurance model we've seen, the service model that we've seen is not really effective at controlling anything. Rather, you can spend trillions of dollars like the US and still have worse medical outcomes than Cuba. So we have to decide whether we need to go towards that model or whether we need to progress towards a wellness and a fitness model, which I think all of us have been stressing on, preventing risk factors, making sure that all the incentives are aligned together. Everybody is working towards keeping the patient healthy rather than treating sicknesses. So that is, I think, maybe a utopian model right now, but I feel that is the only way out if India as a country needs to put its healthcare system together.
Right. And we're saying that the government is coming out with wellness centers with perhaps this intention that prevention is better than cure. Thomas, what would you like to say in your closing comments? How can access for patients be improved to the latest drugs? What are the ways that, or the methods or the pathways that could open up for patients?
Yeah, so first I want to just express my agreement with the previous speakers, because I think, if we do a better job at prevention and at early diagnosis, there are less patients that would need this type of innovative healthcare, expensive care for breast cancer. So I think that's the first thing we should do. We should educate people better through those health and wellness centers, educate them not only on prevention and early diagnosis, but maybe also educate them on the available sources of funding for their disease once they have it. So I think we should all take insurance, not to say that insurance model for the funding in the end is the most important, but it does help if there's a fund to help you pay for your medicines later on. And for the poor, I think we need a safety net. And that safety net needs to be something that we either fund through our taxes that we all are paying, or through adding a layer for middle class and the more affluent that are in the same system that are paying premiums, so that the poor can also benefit from those key premiums that those other segments are paying, like we see in Indonesia and Vietnam, for instance.
All right. Dr. Sehgal, you've been there, done it. You've, Renu ma'am, sorry. You have fought cancer. You have fought for your right that the treatment should be reimbursed by your employer. What would you like to say to people watching this show? Our experts have said so many things to us. One is that you need more awareness, but they've also said that you can't just buy insurance and do nothing and then tell, the government, treat me, cure me, or the doctors to cure you. So what would you like to tell people? Awareness, wellness, insurance, what's the matrix here?
Everything, a holistic approach, like awareness, and take care of your health, lead a stress-free life, and take insurance. And I would also like to say that healthcare is very neglected subject in India. So we should provide more budget for the healthcare and more affordable hospitals, research, and advocacy groups for cancer patients.
So that's a really...
Can I make a point? But just
yes,
a
ma'am.
minute.
Yes,
I want
please.
to also use this platform to tell that we want to emulate the West where all the results of malignancies are concerned. But the first treatment of choice for most malignancies in the West is participation in clinical trials. So, and that is what we need to inculcate the culture, even in India, that if there is a clinical trial, most of the clinical trials is standard of care versus a new drug. So the standard of care is always there in the clinical trial, and a new drug, whether it is worthy of its use or not, and if the combination is going to be better than the standard of care or not better than the standard of care. So there has to be a change in the attitude of people towards clinical trials as well.
Ma'am, the clinical trials, how many are done in India? And I mean, how many can, if I want to participate, do it? Because the colleague I spoke of, she took her daughter to New York because the trial happened there. So she did the fundraising to be able to cover the cost of, getting there, staying there, everything. But how many people can do that?
No, but many clinical trials are there available in India also.
Okay.
And many multinationals don't want to come here because Indian patients are difficult to be convinced that you participate in a clinical trial. So they don't like the word clinical trial, but they want everything best.
All right. So we need to be open-minded about, trying these new therapies as well.
Yes, it's not new therapy. It's the standard of care versus
another
another
clinical trial.
Yeah.
All right. Thank you so much to all our speakers for joining us today and discussing a very important aspect of treatment of breast cancer, how to make it affordable as well as accessible. We are grateful to you for coming here and sharing your ideas. So we've understood that we need greater awareness for early detection. We need awareness for a healthy lifestyle so that we do not present with a lot of illnesses. And we need to also increase insurance cover so that we can cover the cost of treatment as well. A big thank you to all of you for joining us today.
Thank you so much.
Thank you.
Thanks to you, Anisha.
Thank you. Thank you.
Very much.
Thank you, ma'am, for joining. Thank you, Sachin sir.
Thank you.
Thank you very much. Bye bye. Thank you.